Sure. I think the mechanism itself is an anti-interleukin 23. And I think one of the really exciting things about interleukin 23 as a class is we've seen multiple different therapies that have come out in this class, three in particular that have been approved within the last couple of years. And what differentiates them is what I would consider efficacy signal, meaning that it's effective in the treatment of Crohn's disease, but also combined with the safety signal. And I think that is really attractive when you think about some of our more traditional therapies, which certainly have worked very well, but sometimes patients have concerns about potential long-term adverse effects, or even in the short term as well, in terms of infectious complications or long-term risks, which are very rare. And I always tell my patients that all of our therapies are way more safe than having uncontrolled disease. But I think that's what really stands out when you think about the interleukin 20, anti-interleukin 23 mechanism, which mirikizumab falls into that class. Well, I think it's really important for a couple of different reasons. One is actually going back to what you asked first about the actual mechanism of action. With some of our older therapies, we've seen mechanistically that you may have a drop off in some of those key outcomes that we look at in terms of corticosteroid free remission, clinical remission over time, that what we call a secondary loss of response. We actually saw a very nice sustained remission out to 3 years, and that's some of the data that we're presenting at ECHO, as you mentioned. So that goes to probably the mechanism of action when we think about anti-IL-23 therapies and seeing that mirikizumab can show that out to 3 years. It's a really important thing that we wanna, obviously harp on when we're presenting these data. That's something we're really excited about. The second thing, though, is there was a group of patients that are being presented at ECHO that were actually endoscopic non-responders that were re-induced at that week 52 mark. And when they were re-induced, actually, there was an ability to actually, if you wanna think about it, do better after the reinduction, and they could be carried out to 3 years as well. So 60% of those patients roughly went into clinical remission and corticosteroid-free clinical remission. So these are patients that didn't have endoscopic response despite having clinical response at week 52. So you could actually do better in terms of their long-term outcomes by reinducing them at that week 52 mark. So sort of two different populations that we also followed out to the 3-year mark. So that sustainability is really key, as you mentioned. I think tolerance to see is really important when we think about IBD in general. Certainly, I think one of the first things that really came from the mirikizumab development program was the development of the urgency numeric rating score, which was developed actually in the mirikizumab ulcerative colitis population in that development program. But urgency is something that we talk about all the time when we think about treating patients with both ulcerative colitis and in this case, what we're talking about is Crohn's disease. Because urgency is a type of symptom that will keep patients from living the kind of life that they want to live. It will keep them from sitting through dinner with their family or their friends. It will keep them from being able to drive to work, doing their daily commute. It will keep them from sitting in a meeting. It will keep them from watching a movie. Urgency is the thing that will have them keeping going back to the bathroom multiple different times. And so finding a way to actually capture a clinically meaningful response in terms of urgency, that's critical. And so to be able to actually show that in an objective way with the urgency numeric rating score in these data, I think is really key to show that sort of over time as well to that 3-year mark that you mentioned. I think the someone that you already mentioned that I think we just don't want to gloss over are the fact that you had that durable clinical remission that would paired very nicely with corticosteroid-free clinical remission. So it's important to know that you feel better, but you feel better off of corticosteroids because that's what our goal should be when we think about managing Crohn's disease. We know the therapy that can do the most damage over time is steroids. And so if we can keep you off steroids and we can keep you feeling well and can keep you in remission, that's key. So I just want to go back to that for 1 second. The second thing that I would say is there were some really objective markers that we saw nice drops in over the 3-year period of time. So we saw drops in CRP, we saw drops in fecal calprotectin. So knowing that these were patients in one population, for instance, in the one that's going to be presented as a digital oral presentation, where we had the endoscopic non-responders, those patients had objective data over time that they had some biomarker data that were getting better corresponding with all of the sort of clinical symptomatic outcomes that we've been talking about. So I think that's the other point I would just try to make. And that also was mirrored in the patients that were already in endoscopic remission or endoscopic responders at the end of the 52-week in the other population that we're going to be presenting as well. Well, I think it's critical because one of the downsides of looking at safety in a short term outcome of a clinical trial is you may not have long enough data points to sort of look at safety as a general rule because you're really only looking at, say, an induction period 12 weeks or in a maintenance period 48 or 52 weeks, depending on which trial design you're looking at. So to be able to look at safety out to 3 years, that's when you might start to see safety signals sort of creep up because the patient's been on the therapy longer, they've had more exposure to other things like that. That's when you would start to see a safety signal. And so, to your point, to not see safety signals that emerge that are outside of what we already know about IL 23, which is a very, very safe approach to treating patients, which I mentioned at the very beginning of our talk, I think that is reassuring. And so, having those data is really overall something that we would really highlight as going with the mechanism of action of IL 23. And so, there's nothing I would say that I'm particularly following that I think we'll see if we follow these patients out to 5 years or to 10 years, because 3 years is pretty reassuring. However, I think it's always important to keep following patients and also to mirror this with real world data that we can collect as well. So there's all kind of real world cohorts that are being collected at the same time that show the same safety signal for mirikizumab and the same safety signal for the IL-23 mechanism. So I think that as providers trying to choose a therapy, that's something that you can lean into as well. Well, I think there's a couple of different things that you can lean on when you think about making a treatment decision. I think obviously you want to know that the therapy works, and that's where induction data and maintenance data come in. But if you have a patient that is in front of you and you've sort of seen the original data that were presented that led to FDA approval in the United States, then you can think, okay, if I get a patient on that therapy, are they going to stay on that therapy? Are they going to continue to do well? That's where I think data like we're presenting with the 3 year data really comes into play. And so, in terms of your question about how positioning, I think this should give providers confidence that if they choose mirikizumab as their mechanism of action to treat a patient with moderate to severe Crohn's disease, if that patient does well, they're going to continue to do well. And so I think this would give confidence if you're looking for that particular mechanism of action. If this patient profile fits the treatment mirikizumab, they should have more confidence today than they did yesterday if they weren't aware of these data at this point. So I think this would do nothing other than to sort of continue to show the robust signal that we've seen with the interleukin 23 mechanism and with mirikizumab in particular. So I think these would be very exciting data to see if I was a provider trying to make this decision. No, I think that these are the kind of data that we're able to see when we continue to follow patients long term in these development programs. And I think this is really exciting to see this continued signal and to see those patients that even got better when they weren't sort of all the way where we want them in terms of clinical remission, free remission at week 52. We see that sort of catch up. That's exciting to me too. So that would be the thing I would sort of go back to that we talked about at the very beginning.